Good morning. I can't tell you how delighted I am to be part of this very exciting day, to see so many of you here to learn and to share with each other. And I must admit that I plan to take some of the ideas that I have acquired just in the last hour back to Atlanta and incorporate them in our Women's Heart Center, because just looking around this ballroom, it is absolutely stunning. And I think that we all need to congratulate the organizing committee, particularly Nicole. Now, what I'm going to address in the next few minutes is transforming cardiovascular prevention for women. And I've subtitled it as Time for the Pygmalion Construct to End. And you'll see in a moment why I have chosen this. These are my disclosures. And let's go back to the year 1912, when George Bernard Shaw produced the play Pygmalion. We know it now much more as the movie and the theater of My Fair Lady. And if you will remember, the protagonist, Sir Henry Higgins, repeats over and over again, why can't a woman be more like a man? And that is really the basis for some of our discussion this morning. And why can't a woman be more like a man? First, as I will show you, there are many non-traditional coronary risk factors that are either unique to women or predominant in women. Even the traditional risk factors that we've all learned, as I will show you, impart a differential risk for women and men. And my message will be that gender-specific risk assessment and risk management have the potential to improve cardiac outcomes for women. The two comments that I've heard as I've gone around the world, our colleagues in South America often say, a woman is not a man with lipstick. In Europe, you hear the comment, a woman is not a small man. Well, we are different. Now, this is probably one of my favorite slides. And what you will see on this diagram is the data for men is displayed in blue and for the women in red. And this is cardiovascular deaths. And these are the trends over the years for men and women. And let's just go up to the year 2000, because as I lectured over those years, what I saw was that the decline in cardiovascular mortality in the United States was solely in men, and there was no difference for women. But just about these years, we began to acquire research, both privately and government-funded research for women, that defined that women had different characteristics, that the prevention, that the diagnosis, that the management, they were features that were unique to women. And the results of this research applied in clinical practice have been stunning. As you can see, since the year 2000, there's been a sharp decline in cardiovascular mortality for women. It's been even more prominent than the decline for men. And then, in the year 2013, for the first time since 1984, fewer women than men in these United States died of cardiovascular disease. And we are delighted to be in second place and hope to stay there. Now, I would just like to summarize some of these features because I think it's familiar to most of you, but it provides a background for our activities today. Cardiovascular disease still remains a leading cause of mortality and morbidity for women in this country. 1 of 4 women will die from cardiovascular disease. But when I started giving these talks all these many years ago, it was 1 in 2. So we have made amazing strides. But the important feature is that the mortality for women from cardiovascular disease is double that from all forms of cancer combined. So this is our major health problem. And as background for this presentation, 2 of 3 women in this country have at least one major coronary risk factor, and that percentage increases in older women. But a word of caution, I've given you the good news, but here's some bad news, and bad news that we all have to work to reverse. The young women among us, women 35 to 54, rather than sharing in this decline in mortality, have had in the last few years a 1% increase in cardiovascular deaths every year. It has reversed the beneficial trends of the past 4 decades. The risk scores for women are increasing, and probably much of it is the obesity epidemic in this country and sedentary lifestyle, which is why I'm so excited at the exercise theme for today. But some of this highlights the importance of preventive screenings for women. And what are we told? Let's start screening at age 40, because that's when the disease appears. I expect that now, as we are seeing more and more women coming into the hospital with heart attack and heart failure and many other things before age 40, anyone who has a family history, who has some of the features that I'll review with you that are unique to women, probably should be screened much, much earlier. And I think this is a message that I'd like to get out into the community. Now, we women are not uniform. This is not a homogeneous group. And let me give you just 2 examples. Almost half of the African American women have some form of cardiovascular disease. There's an amazing amount of hypertension. 44% of African American women have hypertension. It is earlier in onset. It is more severe. It's associated with metabolic syndrome. And our Black sisters have higher cardiovascular rates and mortality than do the white women. And when we see women in the hospital with an acute myocardial infarction, the Black women come to their myocardial infarction with a greater risk factor burden than do the white women. And obviously, it is a result of these risk factors not having been detected and managed. And sadly, in every one of the reports you will see, the African American women are less likely to receive the full spectrum of evidence-based therapies. On the other side of the spectrum are the Hispanic women. And as well Hispanic women have double the diabetes than non-Hispanic white women. You see the numbers up on the slide. But there's a health paradox there. The Hispanic women across this country have lower mortality and a greater life expectancy than non-Hispanic white women. And we have yet to discover what is the secret of the Hispanic women that they are doing better so that all of us can emulate this. Now, what I want to do is spend a few minutes going over the risk factors that are unique to women. And at least as far as I can ascertain through this time of 2017, pregnancy is a feature unique to women. But typically, what do you think of when you think of pregnancy? You think of happy mother, happy family, healthy baby, etc. But unfortunately, there are a number of complications of pregnancy, and we think of those as obstetrical and gynecologic issues. I want to focus some of this as a cardiac issue. And the takeaway message for you as patients, for us as health professionals, is that a detailed pregnancy history is an integral component of risk assessment for women. And somehow, in all of our medical records, the OB data and the general medical data remain separated, and we have to find a way to put them together. Now, pregnancy complications, particularly the hypertensive complications of pregnancy, whether they be just hypertension or preeclampsia, pregnancy-induced hypertension, but also preterm delivery and small for gestational age babies are risk factors for subsequent cardiovascular disease, and obviously gestational diabetes is a subsequent risk for diabetes. Now, we're really not sure why. In school, all of us were taught you have hypertensive complication of pregnancy, you have preeclampsia. That subsides once the baby is delivered. Well, it doesn't. The abnormalities in the vasculature persist. And I'll go over those in a moment. But people have said that pregnancy is probably the first stress test that a woman undergoes. And it is the cardiovascular and metabolic stresses of pregnancy that probably uncover early predictions of cardiovascular risk. I don't think it's these complications that cause the risk. I think there is a shared risk factors, both for the hypertensive and eclamptic complications of pregnancy and for cardiovascular disease. But the woman who has preeclampsia has a 3 to 6-fold risk of subsequently becoming hypertensive, a doubled occurrence of coronary disease and stroke. And as I've said, the disease of the vessels, the endothelial dysfunction remains. It can be seen after delivery by testing, and it's associated with the demonstration of calcium on scanning in the coronary arteries. And we all know that coronary calcium is a marker of atherosclerosis. And some of these risk features can appear perhaps 3 to 5 years after the pregnancy, while the woman is still in her childbearing years. The important feature is that this is a time for intervention. These are women at risk, and we can help them to alter their risk. And as we all know, if you have diabetes during pregnancy, there's a 7-fold increased risk of becoming a diabetic later in life. So again, all of the preventive interventions that we have for diabetes, diet, exercise, weight management, and the like. Now, what about oral contraceptives? And as we, as health professionals, take a history very different from our OBGYN colleagues, and as you, as patients, give a history, it usually says oral contraceptives, yes or no. Well, they're not all the same, and over the years they have changed remarkably. And what we need to have in our medical record is what was the oral contraceptive, how long was it used, because certainly our OBGYN colleagues and all the women know that if you use oral contraceptives when you smoke, there's a 7-fold increase in risk. And many of the physicians will not prescribe oral contraceptives to a smoking woman. But if you have baseline hypertension, blood pressure can increase just a little bit. There's a small increased risk of stroke. Certainly the benefits outweigh the risks, but you have to be aware that the risks are there. And there's a difference with different oral contraceptives. I've just put 2 examples up on this slide. But the important feature is that the woman who takes oral contraceptives, and many women now use them over the decades, must have coronary risk factor screening and intervention for those risk factors that are abnormal. And that really has not been addressed particularly well. And then something new to our world, and that is hormonal fertility therapy. And I've just picked this one study because it is probably the best one available, and it comes from our colleagues in Canada. And this is a Canadian population cohort of women between 1993 and 2010. And they looked at women who had successful fertility therapy. And what they saw is that compared with the general population of women, the women who had successful fertility therapy had less all-cause mortality, non-fatal coronary disease, stroke, TIA, thromboembolism, heart failure. Now, obviously, this is a healthy cohort selection bias, but it applied in their Canadian cohort to all age and income groups. And then you say, well, this is half the story. What about the women where the fertility therapy was not successful, who often had several cycles of hormone therapy and the like? And it's not yet been published, but it was presented at a scientific meeting, and this same group said that with unsuccessful fertility therapy, the women were at higher risk than the general population. So this needs to be part of the story that we acquire as clinicians and that the women as patients share with their providers subsequently. This should not be unique to the OBGYN community. And then probably the major change in clinical medicine for women over the last 4 decades has been menopausal hormone therapy. When I was in school and in the early years of my training, what were women told? Your hormones will protect you when you're young, and subsequently, menopausal hormone therapy. It was advocated to cure everything from wrinkles to dementia and everything in between. And then we began to acquire the data. The data from the heart and estrogen progestin replacement study, which I had the fortune of naming, and we called it HERS, and then the Women's Health Initiative, which was the largest study of women ever done in the US. And what we found is that there was not benefit, but indeed there was some risk. And it totally changed clinical practice. So now menopausal hormone therapy is recommended for menopausal symptoms, but it is not recommended in any form or any way for the primary or secondary prevention of cardiovascular disease. And the recommendations of the U.S. Preventive Services Task Force say menopausal hormone therapy is not recommended for the primary prevention of chronic conditions. It is symptomatic therapy and is recommended at the lowest dose for the shortest duration of time. And that is a 180-degree change from not that many years ago, and illustrates why we women must become involved in clinical trials. The clinical trials will help improve our health. And remember, the only way to acquire data for women is when studies are done of women. You know, recently we've seen in the press the requirement for the National Institutes of Health and the Food and Drug Administration to include women in clinical trials. But there was also a recommendation that for the basic scientists, that they use female animals. Most of the studies were done in male rats because they were cheaper than female rats. And when you, female rats don't like to be in a cage. You put them in a cage and they bite. They're difficult to work with. But the fascinating part about it is that when the basic scientists were looking at tissues, and you asked them, was this female tissue or male tissue or cells? They didn't have the vaguest idea. And I think if you ask a group of kindergartners, they would tell you that if you want to get data for girls, you want a girl tissue cells. Somehow it took a long time for the scientists to figure that out. Okay. That was a side. Now, let's go away from the unique to women then into the predominant among women. And systemic autoimmune disorders, certainly not unique to women, but predominant among women compared with men, very highly prevalent. And these are things like rheumatoid arthritis, lupus, psoriasis, and the like. But I think that what was not generally appreciated is that these women with systemic autoimmune collagen vascular disease have an increased risk of coronary disease and an increased risk of stroke. And indeed, for the women who have lupus, coronary disease is their major cause for hospitalizations and for mortality. So we've seen that the women with rheumatoid arthritis had a doubled occurrence of myocardial infarction and cardiovascular mortality. And at our Women's Heart Center, one of our women's specialists meets with the rheumatologists in their clinic and works with the women to identify whether they've been screened for cardiovascular risk factors, and if risk factors are detected, to institute appropriate preventive interventions. This is the same as we do in our Women's Heart Center, that we meet with the OB people so that the women who've had preeclampsia or gestational diabetes are screened for coronary risk factors. So we're not sending women to a special place, to an extra appointment. We are joining with our colleagues in the other areas to provide optimal care, one-stop shopping for women who have these identified problems. Now let's go back to the traditional risk factors, the ones that we have learned over the years from the American Heart Association and the National Heart, Lung, and Blood Institute, and say, is there a difference when these risk factors are present in populations of women and in populations of men? We know that hypertension, high blood pressure, is the leading cause of cardiovascular disease worldwide. But there is an increase in the population-adjusted mortality risk for women. You see the numbers there, almost double. And the fascinating part is the difference with age. Before about age 45, more men have hypertension than women. And after age 65, it is predominantly women. And there's an amazing correlation between body mass index and an increase in systolic blood pressure in women. So obviously, with this obesity epidemic, we are seeing with it an acceleration of hypertension. As a matter of fact, 80% of women in this country older than age 75 have hypertension, even if they've not had hypertension as young adults, which is why the recommendations are that we all have our blood pressure measured at least every year. But the fascinating part from our epidemiologists is that this increase in blood pressure with aging is not present in non-industrialized societies. So what is it that we are doing in our contemporary industrialized society that causes the increase in blood pressure? How much of it is the increase in sodium intake, all of the lifestyle, lack of exercise, et cetera? It's probably not one feature, but probably multifactorial. But the fact is, when you go into the third world countries, you don't see this increase in blood pressure with aging. Then what about the control of blood pressure? Because we realize that the control of blood pressure, or lack of control, is one of the major precipitants not only of stroke, but of heart failure. And about a third of elderly women have adequate blood pressure control, compared with about 40% of men. So are we not treating the women appropriately and intensively enough, both with lifestyle factors and with medications? Cigarette smoking. We still have about 17% of women in this country who smoke, but what concerns me is that the uptake of smoking behavior is greater among young girls than among young boys. So we are going to see this increasing in terms of a risk. And our colleagues from the United Kingdom have taught us that your woman patient who is a smoker has a 25% greater cardiovascular risk than does a man smoker. Cigarette smoking triples the risk for myocardial infarction in women. And when I talk to our cardiovascular surgeons, they say they have almost never done coronary bypass surgery on a woman younger than 50 who had not been a smoker in the past. So severe and accelerated atherosclerosis. And in this day of cost consciousness, smoking cessation is actually the most cost-effective cardiovascular risk modification that we have in the United States. And we're still not seeing enough of the anti-smoking programs. All of the tobacco settlements that were done a number of decades ago had the provision that that settlement money was supposed to be used for education. We went to our legislature and made them release some of the money, and it's now being used for education. And I suggest that you look at your legislature and make sure where all of that money is and what it's being used for. Now, let's look at diabetes. And diabetes has been called the great equalizer because the men across the lifespan have more coronary disease than women, particularly at younger ages, but the diabetic woman is about at the same risk as a man. Greater risk for women than for men, greater risk of incident coronary disease, of stroke. And when I see a patient with an initial myocardial infarction in the hospital, 25% of women are diabetic as compared with about 15–16% of men. So certainly much more in terms of initial myocardial infarction. And the correlation with diabetes and coronary disease is much stronger for women than for men, obviously. We're not sure what the mechanism is. I've listed a few of them. But what we do know is that the diabetic women have a clustering of risk factors, and they have a worse risk factor profile than men. And that likely is why their risk is increased, and risk factors are not treated as well. We've just completed a smartphone app study at Emory, where what we did was use the smartphone to help our indigent diabetic women track and control their risk factors, not even control of the diabetes, just the risk factors. And we had devices that were connected to the phone so we could monitor blood glucose, blood pressure, physical activity, body mass, et cetera, and developed a program where the phone talked back to the women and gave them messages about how they were doing. And I think this is some of the future, the technology-based education, if we can personalize it well enough. And that's some of the discussion that we're having with our technology colleagues. And the diabetic women were the sole subgroup that didn't have an improvement in mortality. And again, as I've suggested to you, in all of the studies published in the literature, diabetic women first have less appropriate control of their diabetes and less control of the risk factors, and the data are available in the literature only for the privately and government-insured women, and there are no data for uninsured women. And you can imagine that the data would, if collected, would be far worse for the uninsured women, which is the population that I serve. Now, cholesterol management. About 3 years ago, the guidelines in the US just shook up the cholesterol management in the world. Certainly cholesterol is the highest population-adjusted risk for women, and we know from all of the studies that there's similar benefit of statin medications for women and for men. But in 2013, all sorts of things happened. We received guidance from the government, and I really like this, on new risk equations. I think many of you have heard me say that the Framingham risk score underpredicts coronary disease in women, as does its modification, the Reynolds score. This new pooled cohort risk equation has a separate documentation for women and for men, for African Americans and Caucasians. Data are less powerful for other racial and ethnic minorities. But in these pooled cohort risk equations, which is what we all use, you can define the level of risk. And what we say is that it's not a one-size-fits-all. The intensity of the intervention is appropriate for the intensity of the risk. Now, we always had goal-directed therapy. This is your LDL goal. But when the scientists look at the studies, none of the studies related to treating to goal. It was either high-dose or low-dose statins, or high-dose compared with normal, et cetera. So now we don't have goals. Most of us still have goals in our head, but we're not treating to goal, and we're not measuring cholesterol every 3, 4, 5 months. But if you're high risk, you get a high-intensity statin. If you're low risk, you get a low-intensity statin. But the recommendations that came out said moderate dose statins once you get to 75 years. Statin metabolism changes with aging. But I don't say to the patient, congratulations, you're 75 years old today, I'm going to change your statin dose beginning tomorrow morning. That's not the way risk works. And the woman who has done reasonably well on high-dose statin therapy, or the woman who's had a heart attack recently, I'll keep her on a high-dose statin. We rarely now are starting statins de novo at elderly age because the patients who are appropriate for therapy have already been on it. And I think we're going to get some clarification. And on the guidelines that we received back in 2013, it did not recommend non-statin therapy. But we have 2 very good studies that were published since 2013, and we need some updating of these guidelines. And, you know, I've discussed in many settings that what do we clinicians do? We juggle multiple guidelines, and a woman's heart is often in the balance. But we have 2 new studies showing that there's another drug that can lower cholesterol that we may choose to add, And now we have new study on a biologic, the PCSK9 inhibitors. So we now have, in addition to statin, ezetimibe and PCSK9 inhibitors. And we have to keep up with the therapies and wait till the guidelines catch up with us. You know, I've spent a great part of my life writing guidelines. But what I've always said is that these are guidelines. And what's needed between the guideline and the patient is a clinician who knows how to think. And that's the way we use guidelines in clinical practice. And I think what we're going to see, and what I have seen in clinical practice, is that statin use in women has increased because the statin benefit has been emphasized. I think we are seeing less inappropriate use for very low-risk women. We're seeing far less non-statin use, and certainly less laboratory testing. Laboratory testing is appropriate, but as I teach my trainees, when you order a test, or as you as patients, when you have a test ordered, your clinician should be able to say, what are they going to do with the results of that test? And if there's not need for action, or if the test doesn't show that nothing has to be changed, the test probably shouldn't be done. Now, what about obesity? 2 of 3 women in this country are either overweight or obese, and those are now 7-year-old data, and I think the numbers have increased. And what are the concomitants of obesity? And that's where the problem is. Increase in blood pressure, dyslipidemia, physical inactivity, insulin resistance. And obesity increases the coronary risk more for women than it does for men. Again, it disadvantages women. And you know, when we look outside the US, and we're taught to be global individuals, obesity is double in women compared with men in the low and middle income countries. We often think of low income countries as starvation areas, but obesity is a major problem for women in the low and middle income countries, and it's equivalent in the high income nations for women and for men. So really a challenge in the third world for obesity for women. Physical inactivity, and we're going to reverse that with our education during the course of this meeting, but 1/3 of adults are physically inactive, slightly more women than men, and in the InterHeart study, looking not just at the US, but worldwide, the protective effects of exercise were greater for women than they were for men. Physical inactivity is the most prevalent risk factor for women in this country. About 1/4 of the women have no regular physical activity, and 3/4 have less than the recommended levels of physical activity. But importantly, we have specific data for women from the Nurses' Health Study. And in the Nurses' Health Study, the women who exercised regularly were less likely to develop diabetes than the women who didn't. And the women with diabetes in the Nurses' Health Study had fewer cardiovascular events if they exercised than if they didn't exercise. So very important data specific to women, and we've not used those enough. Now, for secondary prevention, there are comparable recommendations for cardiac rehabilitation for women and for men, but women are 55% less likely to participate and to complete than are men. So we really have to tailor interventions to encourage women who've had an event to participate in cardiac rehabilitation, to continue, and to complete. Now, often we don't think of depression in the setting of risk factors, but it is one that selectively disadvantages women. In the InterHeart study, again, the psychosocial factors, whether they were stress at home or at work or financial stress or major life events, they predicted cardiovascular mortality far greater for women than for men. We know that depression is associated with a substantial increase in cardiovascular mortality independent of the severity of the depression. And I think it may not be the depression per se, but rather its concomitants. And that's a lot of the high-risk behaviors that are associated with depression, non-adherence to recommended therapies, and the like. And in a number of studies, including one coming out of our institution, there was greater mortality in depressed women who had established coronary disease, and particularly myocardial infarction, than in non-depressed women. We see depression as an adverse risk factor with hospitalization for acute coronary syndrome, and we're likely to see more of this with the increase that we have in global violence and global financial instability. But not only throughout the world, but also in the US, we have major cultural taboos that limit access to care, and we have to be part of the elimination of these cultural taboos. I'm just going to use one drug as an example of drug differences for women. Simply aspirin. Aspirin is routinely recommended for primary prevention of cardiovascular disease in men, but not in women. And the reason is that years ago in the Physicians' Health Study, men had a benefit for myocardial infarction, but not for stroke if they took aspirin. You have to remember, though, that the dose of aspirin used in these research studies was 100 milligrams every other day, because that was the pattern of aspirin use when these studies were initiated. But more recently, in the Women's Health Study, we have data specifically for women, almost 40,000 healthy, low-risk women, where stroke was prevented, but not myocardial infarction below 65 years of age, bleeding risk prominent for women. And in women older than age 65, there was a slight benefit for myocardial infarction, slight benefit for stroke, but it was almost completely counterbalanced by a bleeding risk. So the recommendations to the clinician and the patients is individualized. I want to spend just a moment toward the end talking about cardiovascular awareness in women. And this is perhaps one of the themes of this meeting, as it has been of the prior ones. Because the woman who does not believe she is vulnerable will not heed preventive information and preventive interventions. And what we find is that today, only about half of the women in this country recognize that heart disease is their leading cause of death. And this is after 15 years of national education and awareness. The National Heart, Lung, and Blood Institute's Heart Truth Campaign and the American Heart Association's Go Red. We've had 15 years of intensive interventions, and what happened is the awareness increased from about 30-some-odd% to 50-some-odd%. But it has plateaued in recent years, and my concern is that the lack of awareness is greatest in the highest risk women, and those are women of racial and ethnic minorities. But we as healthcare providers are not free from this bias. The lack of provider awareness of the risk for women has translated into suboptimal application of preventive interventions, less appropriate diagnostic testing, and we'll be talking about testing later today, less adherence to evidence-based guidelines, and not surprisingly, poorer outcomes for women. We've talked about the fact that women were underrepresented in trials, and therefore the evidence base is weaker, and we need more women in trials. But you know, today, what do we talk about? We talk about personalized medicine. And my take is that the first step to personalized medicine is incorporating the information about sex and gender differences. I want to tell you something that happened back in 2011. Because this was the first time the United Nations had a summit on health since the AIDS summit of 20 years previously. It was a summit on non-communicable diseases. And I read through the 960-some-odd pages of that, and I pulled out a few things that I think are relevant. And that there is a major gender disparity in risk and in access to diagnosis and treatment of cardiovascular disease, and that is very closely linked to the empowerment of women and the education of girls. Almost 10 million cardiovascular deaths in women worldwide, and that accounts for 1/3 of all the deaths in women. And it very adversely affects women's contributions to society in productive roles, in reproductive roles, as consumers of healthcare, as providers of healthcare. And why are women so vulnerable? 60% of the world's poor are women, and 2/3 of illiterate adults are women. Very important. So, what are the challenges and opportunities? Thank you. Cardiovascular disease is about probably half of all the non-communicable deaths, more in low-income countries. And what we have seen in the low-income countries, we have to really be aware of what's going on in the world and try to help. Unfavorable changes in lifestyle, urbanization, Western diets, processed foods. So what we're seeing is an increase in obesity and hypertension, dyslipidemia, and diabetes. 120% increase in cardiovascular mortality in women expected in developing countries as compared with about 30% here. And the most important feature is in that Interheart study, modifiable risk factors accounted for 94% of the population-adjusted cardiovascular risk. So we can do something about it. Finally, what do I see as the key global issues? We are responsible not only for our own area and our own country, but we must contribute to the world. We have to educate the population, and women in particular, about cardiovascular risk factors, that they're modifiable. Many of them are behavioral. And women must appreciate that lifestyle modifications can decrease the occurrence of hypertension, dyslipidemia, obesity, diabetes, and cardiovascular risk. And they're simple things: smoking cessation, appropriate diet, and exercise. We have to have messages targeted to women, not only here in the US, but especially in low and middle income nations. And the organizations directed toward women's heart health have to engage women on a community level. What we are doing here today, we must see is being done around the world, because that is the way to lessen the risk of cardiovascular disease, heart attack, and sudden death in women. And I've said that heart disease in women is not solely a medical problem. It is highly impacted by education, information, economics, policies, et cetera. So that what we need are programs and policies and national plans for cardiovascular prevention that target women, and that is the way to improve women's heart health. And I thank you for your attention.